The diagnosis will be renal vein thrombosis. So we have to give anticoagulant to the patient as a prophylactic measure. So if the patient presents with nephrotic syndrome and if the patient is children, we can generally think that it's a case of minimal change disease. Especially the cancer, any kind of cancer except the non-Hodgkin lymphoma that is associated with minimal change disease. So there may be lung cancer, the gut cancer, the ovarian cancer, and any kind of cancer is associated with membranous nephropathy. So our next topic is nephrotic syndrome. So we have all know about the nephrotic syndrome. There are some features, if present, we call it nephrotic syndrome. So what are the features that may consist with nephrotic syndrome? First of all, there will be proteinuria. The protein pass in the urine is more than 3 grams in 24 hours. As protein is passing through the urine, there will be hypoalbuminemia. And as there is hypoalbuminemia, there will be edema. So all the features if present, we call it nephrotic syndrome. As protein is losing through the urine, through the protein, there are important factor, the protein that also loses in the urine, that is antithrombin 3, protein C and protein S. As this protein is associated with reduce the thrombus formation or reduce the formation of thrombus in the blood, so loss of this protein is associated with increased risk of thrombosis, in the formation of thrombosis in the blood vessel or blood channel. So we have already discussed about it. If a patient with nephrotic syndrome, we have to prophylactically giving the patient anticoagulant to prevent this formation of thrombus. So let's talk about the classification or causes of the nephrotic syndrome. So what are the things actually associated with nephrotic syndrome? There are some causes. So there are some primary cause like minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis. These are the things that is associated with nephrotic syndrome. Minimal change disease that affect the children. So if the patient presents with nephrotic syndrome and if the patient is children, we can generally think that it's a case of minimal change disease. And the patient present with nephrotic syndrome, in case of adult, we can think it a membranous glomerulonephritis. And in case of young adult, if the patient is HIV patient or the patient is taking heroin or there's some other risk factor, we can think focal segmental glomerulosclerosis. It's associated with HIV, heroin. And membranous nephropathy is associated with hepatitis B virus and cancer. All kind of cancer is associated with this condition. And minimal change disease is associated, it's mostly idiopathic but sometimes associated with non-Hodgkin lymphoma. But Hodgkin lymphoma is associated with membranous nephropathy. Okay, so there are some other systemic diseases that may be associated with nephrotic syndrome like rheumatoid arthritis, systemic lupus erythematosus, Sjogren's syndrome, thyroiditis, amyloidosis, and some drug is also associated with this condition like gold and penicillamine. Very, very important, we have to keep it in mind. This is a 5-star topic. So in the background of nephrotic syndrome, we will always find any associated disease. If the patient is children, there is feature of non-Hodgkin lymphoma like there is B symptom like weight loss more than 10% in 6 months. There is night sweats and fever, evening rise of temperature. These are the B symptom for Hodgkin lymphoma or non-Hodgkin lymphoma. Or there may be underlying drug like NSAIDs, history of NSAIDs can be there. In case of membranous nephropathy, there will be underlying disease like HIV or hepatitis B, most importantly hepatitis B or hepatitis C infection, some underlying other disease, and especially the cancer, any kind of cancer except the non-Hodgkin lymphoma that is associated with minimal change disease. So that there may be lung cancer, the gut cancer, the ovarian cancer, and any kind of cancer is associated with membranous nephropathy. And focal segmental glomerulosclerosis is associated with HIV. We will find on the background of HIV or heroin exposure. We'll think about FSGS. So let's talk about the complication of nephrotic syndrome. So we have already mentioned that there is increased predisposed to thrombotic episode. Why there is predisposed to thrombotic episode? Because as most importantly, the loss of antithrombin 3, protein C and protein S, those are the protein that loses through the urine. For that reason, there is increased risk of thrombosis. Very, very important for the exam, as there's some question that came in the Mrcp part 2 previously. A nephrotic syndrome patient come to you with a sudden onset of severe tummy pain, and there is a hematuria or AKI-like presentation. What will you think? We'll think that it may be renal vein thrombosis, as there is loss of this protein. So there will be formation of thrombus in the renal vein, and patient may present with low in pain and hematuria. Very, very important for the exam. Okay, so let's talk about some other complication. As there is increased risk of infection. Why? There will be loss of immunoglobulin through the urine. For that reason, there is repeated infection will be occur in this patient. So we have to give prophylactic antibiotic to the patient. So increased risk of thrombosis, most importantly renal vein thrombosis. Renal vein thrombosis, we have already mentioned it here. So patient will present with low in pain and hematuria. So nephrotic syndrome patient present with low in pain and hematuria, the diagnosis will be renal vein thrombosis. So we have to give anticoagulant to the patient as a prophylactic measure in this case. So there may be hyperlipidemia and hypocalcemia due to vitamin D deficiency, and acute renal failure may also occur in this kind of patient. So these are the complications we need to keep in mind while reading the nephrotic syndrome. Let's discuss one of the question here. So there is a question: 48-year-old non-rheumatoid arthritis patient is admitted via A&E with a 1-month history of intermittent left flank pain and bloody urine. So there is flank pain and bloody urine, and patient on the background of rheumatoid arthritis. She has no diarrhea or rectal bleeding. She has been a bit tired over the last few months and recently saw her GP because she was worried her ankles are swollen. So there is ankle swelling. He has a past medical history of hypertension. Her regular medication is penicillamine. Patient is taking penicillamine and valsartan. On examination, her abdomen is soft with mild left flank tenderness. There is no palpable hepatosplenomegaly. She has pitting edema on the both knee. DP stick shows 3+ proteinuria and RBC 1+. Okay. Her blood test shows mildly anemic, platelet normal, WBC normal, sodium, potassium, urea elevated, creatinine markedly elevated, CRP normal, bilirubin, ALP, AST seems to be normal. So what is the most likely cause of her flank pain? So look at the question again. The patient is rheumatoid arthritis and patient was taking tablet penicillamine and valsartan. So we have already learned from the previous topic that penicillamine is one of the most important cause of nephrotic syndrome. So most likely patient is rheumatoid arthritis taking penicillamine for a long period of time. So she has developed nephrotic syndrome, and there is loss of protein, antithrombin 3, protein C and protein S, and increased risk of formation of thrombus. So there is renal vein thrombosis, and for that reason the patient presents with flank pain and hematuria. So what are the options here? Inflammatory bowel disease, there is nothing mentioned here about inflammatory bowel disease.